Welcome to Pathology Snippets. Sickle cell anemia is a disease that presents early in the childhood with features of low hemoglobin, painful crises, fatigability, and recurrent infections. Let us see what happens to these children at the cellular level. We know that the major bulk of a red cell stroma is occupied by hemoglobin. Every single red cell contains about 300 million hemoglobin molecules. Each hemoglobin is composed of two pairs of similar globin chains, each of which is attached to a heme molecule. Amino acids are the building blocks of the globin chain. Each globin chain is formed of 150 amino acids. Sickle cell disease is a defect in the hemoglobin. Hemoglobin A makes about 95 to 98% of the hemoglobin seen in an adult red blood cell. This is the primary hemoglobin affected in sickle cell anemia. In hemoglobin S, there is mutation of the HBB gene located on chromosome 11 that encodes for the beta globin chain. As a result of this mutation, there is substitution of thymine for adenine. Encoding of valine instead of glutamic acid in the sixth amino acid position in the beta globin chain. There is an autosomal recessive pattern of inheritance. Each hemoglobin molecule carries 4 molecules of oxygen, each of which is bound to a heme molecule. When oxygen is removed from the hemoglobin, it becomes reduced to deoxyhemoglobin state. In sickle cell anemia, the deoxygenated hemoglobin S has one of the valine residues that becomes sticky in its nature and self-associates by forming intermolecular bond between the hemoglobin chains. This leads to development of hemoglobin polymers. These polymers are composed of 14 hemoglobin molecules that form a helix when in the deoxy state. These polymers deform the discoid-shaped RBCs into elongated, crescentic, or sickle-shaped red cells and are hence called the sickle cells. The sickling process is aggravated by acidosis, wherein the affinity for oxygen is reduced. Similarly, in cases where there is a low flow within the blood vessels, there is increased transit time for the red cells within the tissues, and hence there is excessive deoxygenation of the red blood cells by the tissue components. Repeated episodes of polymerization and sickling causes damage to the red cell membranes. Thus, patients with sickle cell anemia or sickle cell disease have 5 to 10% of the red cells that become irreversibly damaged. The sickle red cells are less deformable compared to the discoid red blood cells, and thus, as they travel through the blood vessels, they eventually become fragmented, causing hemolytic anemia. Sickle red cells becomes fragmented red blood cells that leads to a drop in the red cell count, eventually causing hemolytic anemia. The pattern of hemolysis in these cases are an intravascular hemolysis. These fragmented red cells also release hemoglobin. which are bound by the free haptoglobin within the serum, and hence it causes a fall in the serum free haptoglobin levels as well. The released hemoglobin gets converted into unconjugated bilirubin, that is manifested as jaundice in these patients. They also have a higher risk of formation of gallstones. The lifespan of a sickle red blood cells is therefore reduced to 17 days. As a result of the intravascular hemolysis, there is erythroid hyperplasia within the bone marrow. This is manifested as increased production of reticulocytes in the peripheral blood. It also leads to marrow expansion, which manifests as maxillary prominence and a visible hair-on-end appearance of the skull, as seen in radiology films. Intravascular hemolysis also causes extramedullary hematopoiesis, that is manifested as hepatomegaly. We know that the red blood cells are negatively charged due to the presence of homogeneously distributed sialic acid residues on their surface. This negative charge helps them to repel each other as well as from the other negatively charged surfaces, particularly the endothelium. In sickled red cells, the sialic acid residues are randomly distributed and are sparse. That gives a relatively lower negative charge to the sickled red blood cells, as a result of which the sickled red cells can adhere to each other as well as stick onto the endothelial surface, and this causes formation of a thrombus within the microcirculation, eventually leading to vaso-occlusive crises. Due to microvascular occlusion, the patients present with dactylitis and avascular necrosis of the small bones. There is also splenic infarct and splenic sequestration seen in these patients that eventually causes autosplenectomy due to reduced blood supply. Patients with autosplenectomy can show presence of Howell-Jolly bodies within the red blood cells. These individuals are also highly susceptible to infections due to encapsulated bacteria like the Streptococcus pneumonia, Haemophilus influenza, Neisseria meningitidis, and Salmonella, because these encapsulated bacteria are normally coated by opsonins seen in the serum and recognized by the macrophages within the spleen that engulfs them and eliminates them. Due to autosplenectomy, elimination of these organisms are impaired, leading to recurrent infections because of them. Secondary to microvascular occlusion, these patients can also present with cerebral infarct, moya-moya disease, renal papillary necrosis, as well as acute chest syndrome. These disease manifestations are seen in individuals who have two copies of the mutant gene. Those are people with the sickle cell disease. Whereas a heterozygous individual who harbors only a single copy of the mutant gene will not show clinical symptoms, and these patients are called sickle cell trait individuals. Now, how do we diagnose this disease? Diagnosis of sickle cell disease is mainly by peripheral smear evaluation that gives us clues by the presence of sickle cells in peripheral blood, presence of reticulocytes, nucleated red blood cells, as well as fragmented cells, which are all evidence of an associated hemolytic process. Presence of Howell-Jolly body is an evidence of autosplenectomy in these individuals. However, presence of sickle cells alone is not diagnostic of sickle cell anemia. Assessment of the abnormal hemoglobin by hemoglobin electrophoresis or HPLC is mandatory in these individuals. The normal hemoglobin electrophoresis pattern shows a hemoglobin A band which is located far away from the point of origin. Next to the hemoglobin A is the hemoglobin F and the minor hemoglobin A2 components. But in a patient with sickle cell anemia, you will see that there is complete absence of the hemoglobin A. Instead, between the hemoglobin F and the hemoglobin A2, you can see an abnormal hemoglobin band, which is the hemoglobin S band. Now, in case the hemoglobin electrophoresis shows the hemoglobin A as well as presence of hemoglobin S band in an individual, that individual is a heterozygous individual and is called a sickle cell trait. Sickling test with sodium metabisulfite is the next test that aids in diagnosis. Here, we prepare a 2% sodium metabisulfite reagent by diluting 0.2 grams of sodium metabisulfite with 10 ml of distilled water. Once the sodium metabisulfite is well dissolved in the distilled water, you take 1 drop of the blood and 1 drop of the reagent, place it on a glass slide, cover it with a cover slip and seal the edges of the cover slip using Vaseline or wax. This is then allowed to stand for about 4 hours to up to 24 hours, after which the glass slide is viewed under a microscope to look for presence of sickled red cells. If there is presence of sickled red cells, it is because the sodium metabisulfite, which is a reducing agent, reduces the oxygen tension within that drop of blood that produces sickling. Solubility test is the next test that aids in the diagnosis. Here we use a phosphate buffer of differing concentrations. 1 ml of the high molarity as well as low molarity buffer is taken in 2 different test tubes, to which we add 2 drops of the hemolysate prepared from the patient's blood sample, and 10 grams of sodium dithionite, which is a reducing agent, is added to this mixture. Mix well and then allow it to stand. We then look for presence of turbidity within the test tube. Hemoglobin S is an insoluble hemoglobin in its reduced state, and hence it forms tactoids that gives a turbid appearance to the solution. So, in addition to true positive results, there are other causes of false positive solubility test which needs to be known, which are presence of polycythemia, presence of other hemoglobins like hemoglobin Bart, hemoglobin I, hemoglobin C can all give a turbid appearance on the solubility test. Hence, it is essential to always run a positive and a negative control with the test. Solubility test should always be interpreted with the proper clinical details. Sickling and the manifestations produced by the sickling episodes is not unique to sickle cell anemia. It can be seen when hemoglobin S is seen in association with other abnormal hemoglobins like hemoglobin C, hemoglobin D, and beta thalassemia. treatment of sickle cell anemia is by providing symptomatic relief of the pain by opioids, reducing the episodes of sickling by providing proper oxygenation and adequate fluid therapy, preventing the incidence of infections by giving an antibiotic coverage whenever essential. Blood transfusion has limited role, however, it should be used sparingly in these children as they can lead to secondary hemosiderosis. Penicillin and polysaccharide vaccines are essential to prevent infections against encapsulated bacteria. Hydroxyurea is said to increase gamma globin production and thereby cause increased hemoglobin F that can replace the hemoglobin S and provide relief in these individuals. With this, we come to an end of today's topic. Thank you.